So my name's Samantha. I am a doctor working in obs and gynae and sexual health, and I also work as an editor for Quesmed. So this is an OSCE Masterclass lecture. All the content here is written by myself. All the images used have been used with permission. So all of this remains copyright of Quesmed. So please don't distribute this, but you're free to use it for your own study. So I'm going to go through this super quickly because this was intended as a 3-hour masterclass, but it's going to be condensed into an hour. We're going for quantity here. And I'm just going to stop my camera just because it makes this all run a little bit smoother, but I am still here. So we are covering obs and gynae scenarios that are likely to come up in your OSCEs. This lecture is recorded, so you can go back and pause it and rewind it at the relevant parts. And if you have any comments, please pop them in the chat box. I will try and answer as many as I can at the end. If your audio is not working, try quitting and rejoining. I'm not sure what happens with the audio, but sometimes that fixes it. So I'm just going to crack on with a gynaecology history. So one of the most important parts in your OSCE is your introduction. This sets your scene, and if you nail your introduction, you not only feel confident about the station, but your examiner and your mock patient already view you as competent. So I like to use the acronym WIPE to remind me what to do when I first walk into the room. So wash your hands, introduce yourself, including your full name and who you are, whether you're a junior doctor, whether you're a medical student in this scenario. You want to confirm the patient's identity. Classically, that's with their full name and their date of birth. And you want to explain what's going to happen and gain consent. So for history taking scenarios, this might be as simple as I'm going to ask you a few questions about why you're here. For examination stations, obviously these require a little bit more explanation about how things are going to proceed. So the first step is we want to establish a presenting complaint. We want to begin our consultation by asking broad, open questions that allows the patient to talk and to explain themselves. So something like, can you tell me a bit about what brought you here? What seems to be the problem? Nice open questions. And we then dive into the history of the presenting complaint, and we can ask some more closed questions here. So, when has this been happening from? If we're talking about pain, I like to use the Socrates acronym, but I feel like this also works for other presentations, not just pain. So you've probably heard of the Socrates acronym about site, onset, character, radiation, things like that. Most complaints are pretty amenable to being used with the Socrates acronym. So we then go on to the more nitty-gritty of gynae specific things. So often there's a point in the mark scheme for establishing when menarche was or when menopause is, depending on the age of the patient. Remember, menarche is the age at which menstruation started, and the menopause is the age at which menstruation stops. So it's important to be mindful of why we're asking these questions. So for example, an early menarche is associated with an increased risk of some cancers, so breast cancer, and a delayed puberty might be indicative of some underlying chromosomal abnormality or structural abnormality. And things like irregular periods and dysmenorrhea, they're more common immediately following menarche. So it is useful to know when the person started their periods when we're talking about the presenting complaint. And similarly, we want to know about the menopause because things like postmenopausal bleeding is obviously a red flag for things like endometrial cancer. We also should ask specifically about the menstrual cycle, the length, duration, regularity, and if there's any bleeding in between periods. And again, let's be mindful of why we're asking this and remember what's normal. So a normal menstrual cycle is anywhere from 21 to 40 days. Classically, the textbook menstrual cycle is 28 days. And most women will bleed for an average of 3 to 5 days. But remember, this might be from 1 to 7 days and sometimes even longer. The menstrual cycle should be regular, and if it's irregular, it's important to delineate, is that irregularity new? And intermenstrual bleeding, so that is bleeding or spotting between the normal periods. And again, we want to know, is that new? And that can be related to pathology, it can be related to contraception, it can be related to infection. So important to wonder why that is. And it's always important to ask about post-coital bleeding, so bleeding during or after sex. This can be an indicator of kind of cervical pathology such as cancers. And we should specifically ask about the last menstrual period. The reason we're asking about this is it might lead on to a discussion about where she is in her cycle. Are her symptoms cyclical? So we're thinking about things like Mittelschmerz, that's ovulation pain, things like premenstrual syndrome, things like painful periods, dysmenorrhea, and things like endometriosis. They're all kind of cyclical symptoms. It's important to know where she is in her cycle and have a discussion over whether her symptoms are related to her menstrual period. And we also want to think about her last menstrual period in terms of pregnancy. This is more for obstetric history taking, but do remember that ectopic pregnancy can come up in your gynecological OSCEs. So if her period is late, her period was more than the 28 days that her normal cycle would be, we want to think about ectopic pregnancy, and that's a common scenario to come up in your OSCEs. We want to think about specifically about dysmenorrhea, and that is painful periods. And that's one of the most common gynae reasons to go to the GP or to be referred to gynecology. Now, most women experience some sort of discomfort or pain with menstruation. So I like to ask it in a way of, do you suffer from particularly painful periods, or is period pain a big problem for you? Rather than saying, do your periods hurt? Because I think everyone gets some level of painful periods. And thinking about causes of painful periods, we're thinking about things like endometriosis, polycystic ovary syndrome, pelvic inflammatory disease, fibroids. All of these things can cause painful periods. We also specifically ask about menorrhagia, which is heavy periods. And again, that's another common complaint in the gynecology clinic. And again, we want to think about, explore this heavy bleeding a bit more. We want to ask if we can quantify the blood loss. So a normal blood loss is 5 to 80 mils. I've absolutely no idea what that looks like in terms of tampons or pads, but I like to ask people, how many pads are they using? Are they flooding through several pads in an hour? Are they flooding through several tampons? Are they having to use tampons and pads to soak up their blood flow? How is that affecting them? How is that affecting their activities of daily living? And we also want to think about anemia. So it's really common for people with heavy periods to become anemic. So you might want to specifically ask about signs of anemia. So are they feeling dizzy, tired, breathless? And that will for sure impress your examiner, because you're thinking outside the box. You're thinking of symptoms that are not directly to do with their menorrhagia. And again, there's lots of things that can cause heavy periods. So fibroids being one of the more common ones, and even things that we have done. So if we put a copper coil in someone, that can cause periods to become more heavy. We also want to ask specifically about vaginal discharge, and every woman has vaginal discharge, but it's important to ask about any new discharge or any change in discharge. We also like to ask about the colour, the volume, the consistency, the smell, and if there's any other associated symptoms such as itching or pain. And talking about pain, we do specifically ask if the person has any pain, and we can use our Socrates to explore that. And I like to talk about pain in terms of pelvic pain, genital pain, and dyspareunia. So pelvic pain being pain more in the lower abdomen, vulval pain being more in the genitals, and dyspareunia being specific to pain during or after sex. And we can explore that further. So for example, if someone has dyspareunia, I'd want to ask them, is that a superficial dyspareunia? Do they feel that in their vulva? Or is that a deep dyspareunia? Are they feeling that deep inside? Because again, the pathology can differ depending on where that pain is coming from. We want to specifically ask about smear tests. We want to ask if their smear tests are up to date, and be mindful of the fact that people are only called for a smear test over the age of 25 in this country. I also ask them if they have the results of previous smear tests. So have they all been normal? Have they ever had an abnormal smear? Have they ever needed any treatment to their cervix? And in people under the age of 25, I do ask them about the HPV vaccine. So that's normally given in kind of first or second year at high school, and it's now given to girls and boys. And most people remember getting their vaccination. And this is all giving me an indication of their risk of cervical cancer. Talking about treatment, so colposcopy, that is where you get sent to the gynecology clinic. They look at your cervix through a microscopic camera, just have a closer look at the cervix. A LETS is a large loop excision of the transformation zone, and that is performed where there's abnormal cells. We literally chop out a chunk of those abnormal cells to get rid of it. If there's more extensive abnormal cells, the person may need a cone biopsy, which is taking a larger chunk of the cervix. I also specifically asked them if they've ever seen a gynaecologist or if they've ever had any gynae operations. So particularly in older women, they might have had kind of an operation for a prolapse that they totally forget to tell you about. So that's the kind of things you do want to know. Have they ever been to a gynaecologist for any reason before? Is there any operations we should be aware of? We take a brief obstetric history. Usually in a gynaecology station, there is a mark for asking an obstetric history. So a quick refresher on asking about an obstetric history. So gravidity, that is the number of times a woman has been pregnant, regardless of what happened with that pregnancy. Parity is the number of times a woman has given birth, and that could be vaginal or C-section, to a pregnancy of viability. So by viability, we normally say that's at least 24 weeks gestation. And we normally include miscarriages and terminations in that. So the way it's normally written is gravida A, para X plus Y, where A is the number of times the person's been pregnant, X is the number of times they've given birth to a viable fetus, and Y is the number of miscarriages or terminations below the age of 24 weeks. So that can be a bit confusing. So I would recommend revising your how to nomenclature of obstetric history. We also specifically ask about contraception. Are they using contraception, and are they using contraception correctly? And I'm not going to go into all the methods of contraception, that's a whole other lecture, but the method of contraception can have significant effects on gynecological issues, both positive and negative. So many methods of contraception can cause irregular periods, and other methods can cause sort of heavier periods, more painful periods, can cause periods to become less frequent. And also in terms of contraception, we're thinking about risk of pregnancy. If they have been using their contraceptive method incorrectly and having unprotected sex, in OSCE land, they're definitely pregnant. And in every history taking scenario, we ask about past medical history and past surgical history. We ask about medications, and we ask about family history, particularly cancers, being mindful of the fact that many gynecological cancers have a genetic component. We also take a brief sexual history. So what we're trying to do in a sexual history here is to find out the risk of sexually transmitted infection. So we want to know, are they sexually active just now? Is it a regular or casual partner? And is there any worries about infection? We also want to ask if they've ever been diagnosed with a sexually transmitted infection. And here we're thinking about that as a risk factor for things like adhesions, for things like pelvic inflammatory disease. And as in any other history taking scenario, we ask a social history. So we ask about alcohol, smoking and drug use. And remember, smoking is a risk factor for most cancers, particularly cervical cancer. And OSCE marks often like to make sure that your patient is satisfied. So I like to use the acronym of ICE, ideas, concerns and expectations. And I always ask if the patient has any questions. Sometimes there's a sneaky mark for explaining something to the patient. And if you don't ask them if they've got any questions, you might miss out on that extra couple of marks. So make sure to ask if there's anything the patient wants to ask and score maximum marks. And there's typically a mark for summarising your findings. Now, you don't need to say absolutely everything. You just want to say the important points. And always try and end your history taking session with a suggestion of where you're going to go with this patient. So do you want to examine them? Do you want to refer them? Do you want to perform additional tests? So that's a whistle-stop tour of gynecological history taking. And common scenarios you'll find in the gynae station are things like heavy periods, painful periods, funny bleeding, vaginal discharge. Like I said, ectopic pregnancy commonly comes up, and presentations of cervical, ovarian and endometrial cancer. In the older lady, we're more thinking about postmenopausal bleeding and fibroids. This is not an exhaustive list. They do come up with some weird and wonderful scenarios, but that's the kind of common things you'd want to have a background knowledge of. So let's move on to a more specific sexual history. And remember, we always wipe first. We wash our hands, introduce ourselves, identify the patient and explain. Now, it's particularly important to explain what you're going to do in a sexual history, because taking a sexual history is quite intrusive and patients do find it embarrassing. So it's often worth at this point explaining to the patient that you are bound by confidentiality and try and put them at ease that anything you tell them is going to remain confidential. So again, nice open questions. We want to establish the reason for attendance. And I normally start a sexual history by establishing the gender of the patient and their sexual orientation. And I normally ask a kind of open question here. So rather than saying, are you straight or are you gay? I'd normally say, how would you describe your sexual orientation? And they might come up with something that's kind of less conventional. They might come up pansexual, asexual, all these other things. But it's important to allow them to say that in their own words. And next we want to establish, is the patient sexually active? And quite often they go, what does that even mean, sexually active? Do we mean ever sexually active? Do we mean had sex yesterday? It's quite a vague question. So I usually rapidly follow that up with, well, when was the last time you had sex and who was that with? And we also want to establish their recent sexual history. So we normally ask who else the patient has had sex with in the last 3 months. Why do we pick 3 months? Well, because infections can take up to 3 months to show up. I'm thinking of things like syphilis, where the window period can be up to 12 weeks. We can also ask about lifetime partners. So you can ask, how many people have you had sex with in your whole life? And again, we're just establishing a ballpark, and that's helping us to establish risk. We then want to think about if this person is having sex with casual partners or regular partners. And again, that's to do with risk. Casual partners being at a higher risk of STI. And we then want to think about who they're having sex with. So is that men? Is that women? Is it only men? Is it sometimes men and women? They'll normally tell you exactly who they're having sex with, and that can help you with your risk assessment as well. And we also want to think about where their partners are from. So areas of high prevalence of things like HIV are obviously more risky sexual partners than people from the UK. The UK actually has a very low prevalence of things like HIV. And along that same vein, we ask about sex overseas. So has the person travelled abroad and had sex with lots of people abroad? Again, that's assessing risk. And we want to think about which countries they've been in. What is the prevalence of sexually transmitted infections, particularly HIV? And we then get into the nitty-gritty nosy part of a sexual history. We want to ask what type of sex they're having. So are they having vaginal sex, oral sex, anal sex? And it's important to really dive down into what they're actually doing. So particularly for oral sex, we want to know if they are giving or receiving oral sex, because we're wanting to know where we want to stick a swab for thinking about infections. I also ask about drug use at this point. So you may have heard of the practice called chemsex, whereby groups of individuals take drugs and have sex. And that's a risky practice because barrier contraceptions are often not used, and people can have reduced inhibitions when they're under the influence of drugs, leading to risk-taking behaviours. And we do always ask specifically about condom use. And I ask if they use condoms all of the time, some of the time, or none of the time. And that's also important to ask if condoms are used for oral sex and anal sex as well. Quite often I find that people are happy to use condoms for vaginal sex, but don't feel the need to use condoms for anal and oral sex, forgetting the fact that they can still catch sexually transmitted infections. So often in OSCEs, the marker wants you to verbalise the risk of STI. So now that you have a full sexual history, you might want to just say to your examiner, some kind of indication of risk. So for example, this person's had unprotected sex 4 weeks ago. They are at risk of sexually transmitted infection. So I would verbalise that. And while we're talking about STIs, we can ask about a history of STI, and if any of this person's partners have given any indication that they may have an infection. So sometimes there'll be a text message, you should get checked out, or I've been treated for something, and we want to know about that. We want to know what sexually transmitted infection they or their partner have had, and we want to know if that's been treated adequately. And again, we want to then ask about symptoms of STI. So this is going to differ on the presentation and the person you have in front of you. So for someone with a vagina, we're thinking about things like discharge, funny bleeding, abdominal pain, dyspareunia, any sort of genital discomfort. For the penis owners, we want to think about things like dysuria and penile discharge, skin changes, and testicular discomfort. So you'll tailor that a little bit to who's in front of you. We also want to ask about vague symptoms such as feeling generally unwell, flu-like symptoms. As we all know, that could be a symptom of, for example, HIV seroconversion. We also want to ask about contraception. Again, we are assessing the risk of pregnancy. And again, there is sometimes a mark for verbalising the risk of pregnancy. So if someone's not been taking their pill properly or they're late in having their injection, we want to verbalise to the examiner that we're aware that there is a risk of pregnancy. We always ask about commercial sex work. So I say, have you ever paid or been paid for sex? Now, commercial sex workers often need more frequent testing for STIs, and they might need additional support for effective contraception and safe spaces to practice. So we do always ask that. And we always ask about non-consensual sex, sexual assault, rape, and other assaults. And that's just to make sure that we can signpost people to the appropriate support services if they do disclose an assault to us. We obviously ask about the normal stuff, so past medical history, family history, drug history, and social history as normal. And we explore the ideas, concerns, and expectations of the patient. And again, we ask if the patient has any questions. If they have anything they want to ask. Again, there can be extra marks in there for answering a patient's questions. So if you don't ask, you'll miss those marks. And quite often in sexual history taking stations, there's a mark for providing advice. So the marker might say to you, what do you want to do with this patient? So you need to acknowledge that they might have had a sexual risk. There may be a risk of pregnancy. You might be required to explain window periods. So window periods are important. So things like chlamydia and gonorrhea, they take up to 14 days to show up on a swab. HIV classically takes 45 days. And syphilis and hepatitis can take up to 2 weeks. So that is a common scenario where the marker will say, can you explain the window periods to this patient? Important to remember those. We obviously summarise and we offer some next steps. So the next steps might involve a pregnancy test, might include STI screening, might include discussing window periods and repeat testing, or it might involve discussion over contraception. So moving on, we're going to move on now to the bimanual examination. Apologies if this is going fast. I did say I was going to rattle through this very quickly. So remember, we always wipe first. We wash our hands, introduce ourselves, identify the patient and explain. So when explaining a bimanual examination, be quite thorough and quite specific. Patients in real life had fed back to me that one of their biggest fears in seeing a doctor for a bimanual examination is that they don't know what's going to happen during the examination. So it is really important to explain properly what exactly is going to happen. Advise them on how to position themselves and always allow your patient privacy to get undressed. Reassure the patient that they are in control and they can stop the examination at any time. Also explain the point of a chaperone. So I normally say there's going to be a nurse or a healthcare assistant in the room with me. They will not participate in the examination. They are here as a chaperone only. And finally, obviously, gain consent. So the first part of your bimanual examination should be an abdominal examination. So you do palpate all of the 9 areas of the abdomen, not just the pelvis. And we're looking for, in particular, any swellings, any scars, and when we palpate, we want to palpate both superficially and deep, checking for any masses or areas of discomfort. And when we go ahead to go to the bimanual examination, we want to think about positioning, and there's often a mark specifically for explaining position. So normally in your OSCEs, you won't have a gynaecology bed, you'll have a flat bed. So we use the modified lithotomy position. And that basically involves asking the woman to have her heels together up towards her bum and to let her legs flop out to the sides. And we call that the modified lithotomy position. We can then don our non-sterile gloves. You don't need to use sterile gloves for a bimanual examination out with pregnancy. And we would start with inspection of the external genitalia. So here we're looking for any scars, any anatomical abnormalities, any obvious discharge, any evidence of infection, any evidence of skin changes, of atrophy or lichen sclerosis. And just to remind you of the anatomy of the external genitalia, and I think it looks really good in your OSCE if you know all of these Latin terms. If you're able to use the correct clinical jargon, you will totally look like you know what you're talking about. So that's useful to know. And it's also useful to just know what the normal vulva looks like. And I'd recommend looking at this resource called the Labia Library that contains literally hundreds of pictures of vulvas, just so that you've got a good idea of what is normal, because there is a huge variation in normal vulvas. Before you go on to touch the patient and perform the bimanual examination, ask the patient to cough. And this is to check for both urinary incontinence and any signs of vaginal vault prolapse. We then start with palpation, and I start with palpating the lymph nodes, because I think that's the least invasive part of palpation. And just to remind you of where the lymph nodes are that you're looking for these inguinal lymph nodes, and they're just underneath the inguinal ligaments. If you can palpate the hip bone, the anterior superior iliac spine, and you can palpate the pubic bone and draw an imaginary line in between those, you'll feel those lymph nodes just inferior to that. And they're usually pretty easy to find if they are enlarged, as they are quite superficial. We then can move on to palpation. So when we're looking at the external genitalia, we want to have a wee look at the labia, see if we can see a Bartholin's gland. Now, a Bartholin's gland is not normally palpable, and it's normally just in the labia, just to the size of the introitus. So you might want to comment that you cannot feel a Bartholin's gland. And we then move on to palpation proper. So to do palpation, you want to lubricate both your index and middle fingers of your dominant hand. You want to separate the labia and gently slide your fingers into the vagina. I tend to introduce my index finger first and then introduce both fingers rather than just going with both fingers at the same time. And you want to palpate all of the vaginal walls. You want to palpate left, right, anterior and posterior. And what you're trying to feel for there is, can you feel any evidence of a prolapse, any funny bulges, and obviously, can you feel any masses? We then want to focus on finding the cervix with our fingertips. And once you've located the cervix, you want to comment on the size, shape, consistency, mobility, and if you can feel the os. So a normal size cervix is usually about 1 inch. It's roughly cylindrical in shape, and it feels pretty firm, kind of like the end of your nose. And you should be able to move it around with your fingers without causing too much discomfort. And it's quite difficult sometimes to feel the os, as it should be closed. So we then go for the bimanual examination. And for this, we bring our non-dominant hand into place on the abdomen. And we want to press on the lower abdomen. And what we're aiming to do there is to trap the uterus between your 2 fingers that are in the vagina and your top hand, which is on the abdomen. And you can then sort of bob the cervix and the uterus back and forward between your 2 hands. So we comment on the position. So if you can feel the uterus bobbing up against that hand on the tummy, chances are the uterus is anteverted or tipped forwards. And that is the case in 80 to 90% of women. We want to assess the size. So a normal uterus is about the size of an orange or an avocado, and it's only just palpable underneath the pubic bone. If you can feel the uterus way up at the belly button, you would call that an enlarged uterus. And the shape, you shouldn't feel any lumps or bumps, any craggy bits, any irregularities. If you do feel any irregular shape, that might indicate fibroids or other masses. And while you're bobbing, you're assessing for mobility. So can you move the cervix freely? Is the uterus free in the abdomen? And if you feel like you can't really move anything, you would describe that uterus as fixed. And that might be a sign of adhesions or malignancy. And obviously during all of this, we are feeling for masses. So this picture just shows a kind of side-on view to what you're trying to do here. And you can see there that uterus is being kind of trapped between the finger and the top hand on the abdomen. We're bobbing it between the 2. We then palpate the adnexa, and that's up into kind of the corners where you would normally find ovaries. Now, normally you can't feel ovaries unless in a very slim person, but you would feel things like an ovarian mass. So if you do feel a mass there, that is usually abnormal. Also be mindful of eliciting any sort of tenderness, as that can obviously be any kind of PID, things like that can elicit tenderness when you're feeling up into the adnexa. And once you withdraw your fingers, you want to have a look at your fingers. Can you see any discharge? Can you see any blood on your glove? And obviously we cover the patient back up and let them know they can get dressed, and again offer them privacy. I think it's nice to offer the patient some tissue, as they will probably have lubricant at their vulva, which doesn't feel very nice. And you want to summarise your findings and suggest further investigations. So in this scenario, you might want to do a speculum examination, you might want to take swabs, you might want to take a smear, or if you found something abnormal, you might want to refer them straight away for a pelvic ultrasound or refer them to gynaecology. So let's go on to speculum examination, which is possibly the next thing you might want to suggest to do. Again, we wipe first. we explain the process. So I normally start by asking someone if they've ever had a speculum examination before. So if they've had a speculum examination before, you can obviously explain that it's a roughly similar procedure. So if someone's had a smear test before, they've had a speculum before. But for someone who's never had a speculum examination, you do want to explain that in quite a bit of detail. You want to say that you're going to insert a small plastic tube inside the vagina to get a better view of the cervix. I normally say it feels a bit full and stretchy. It might be a bit uncomfortable, but it should not be painful. And again, ensure your patient knows to tell you if anything hurts or if they want you to stop. And again, mention the chaperone, tell them what their purpose is. So again, in terms of preparation, make sure you've got everything you need to hand. I normally open the speculum and open the lubricant ready, just so that I'm not fumbling about with things after I've, say, done a bimanual. And again, we start with inspection, and that is exactly the same as the bimanual. We're looking at the external genitalia, looking for any abnormalities. And we then proceed with inserting the speculum. So I use plenty of lubricant in a speculum. You insert the speculum with the blades closed, and I normally be sure to part the labia to expose the vaginal opening, the introitus, just so that you can avoid trapping the labia inside the blades, which can be quite painful. And you normally insert the speculum with the blades pointing kind of sideways, with the handle pointing to the side, and you can rotate the speculum once you are fully inserted. Now you can have the handle either facing up or facing down, it's entirely up to you. Sometimes if you're on a flat bed, there's not quite enough space to have the handle facing down towards the bum, so you might have to have it facing up towards the top, but that's really personal preference and you shouldn't be marked down for either way. We then open the speculum blades and we do this slowly and gently under direct vision the whole time. And ideally the cervix just pops into view, and we can then secure the speculum by tightening the locking nut. Some speculums have a wee twisty bit of plastic that locks the speculum. The metal ones have a proper kind of nut and bolt mechanism to lock it. So be familiar with different types of speculums as well. If you can't see the cervix, that fills medical students and junior doctors with dread. Don't panic. There's many things we can do to find the cervix. So when you're opening the blades, if the cervix doesn't pop straight into view, I like to try a gentle twisting motion of the speculum, and quite often the cervix just pops right into view. If you're still not seeing the cervix, you might want to remove and reinsert the speculum at a slightly more posterior or anterior angle. You might want to alter the patient's position. You might want to flatten the couch if they're sitting upright. You might want to elevate their pelvis. So you can pop a towel under their bum, or you can tell the patient to pop their hands under their bum. That just lifts the pelvis a little bit and can make you a bit of a better angle for seeing the cervix. If you still can't see it, you can say to the examiner that you'd like to perform a digital vaginal examination. And there you can pop your fingers inside the vagina and see if you can feel the cervix with your fingers. And obviously then that gives you a bit more guidance as to where you're aiming your speculum. And if the cervix feels miles away, if you can't feel it with your fingers, it is perfectly fine to use a larger or longer speculum. In some people that have very flaccid vaginal walls, for example, people that have given birth recently, you can use a condom where you chop the top off it and you can pop the condom over the speculum, which helps hold flaccid vaginal walls out of the way. So lots of tips there. Don't panic if you can't see the cervix straight away. So now that we've managed to find the cervix, take a good look. So does it look normal? Is there any evidence of normal variation? So for example, an ectropion, if they've had evidence of procedures to their cervix, so a large loop excision, do they have any Nabothean follicles, which are a normal finding? Can you see any polyps? And can you see any coil threads? Those are all kind of things that you might find. Is there any signs of infection? So we're thinking of things like discharge. Can you see ulcers on the cervix that might indicate herpes? Or is there a barn door malignancy? Does the cervix look like it's got some weird growth on it that you're worried about malignancy? And you can comment on the os. So the os in most cases will be closed. If the os is open, that might indicate they've recently given birth, or if it's a pregnant person, the os can sit slightly open. And at this point, you might want to suggest to your examiner that if the person was presenting with a discharge, you might want to do your swabs at this point. Then you'll seem super slick and you know what you're doing. So conclude the speculum examination, you unlock the wheel, you partially close the blades of the speculum, and you slowly rotate and withdraw the speculum in the opposite motion to which you inserted it. You want to have a wee peek at the vaginal walls on your way out, just to make sure that there's no evidence of funny discharge or any kind of masses. And summarise, you want to cover the patient back up, you want to summarise your findings, and again, you want to suggest further investigations. So a few more specific things you might be asked to do in a gynae station. So a smear test. Again, smear tests in Scotland, they're performed every 5 years from the age of 25 to 64. And to get the most accurate results, ideally, the person should not have had sex for at least 24 hours. Ideally, they should not be on their periods or have used any sort of intravaginal products, not have any infection, not be pregnant, or not be immediately postnatal. So the usual introduction, identifying yourself, getting a chaperone, having the patient in the correct position. And you want to, again, make sure you've got everything to hand. So make sure that you've got your speculum, you've got your lubricant, you've got your sampling brush, and you've got your cytology pot. And I normally open everything up. I've got the cytology pot open just so I'm not fumbling about. And this is what a cytology brush looks like. So you can see there's kind of longer bits in the middle, tapering out to kind of more shorter brush tips. And that's the wee pot that smear tests go into. So exactly the same as a speculum examination, you would still comment on the external genitalia, you would insert the speculum in the usual way, and you would comment on the appearance of the cervix. Now, with taking a smear test, they do normally want you to use a water-based lubricant or no lubricant. Some of the more jelly lubricants can actually interfere with the test results. So you do normally lubricate with a water-based or just plain water. To take the actual smear, I normally warn the patient that it can feel a bit crampy. It can feel like a sort of period pain. You insert the long bits of the brush just into the external os, and you rotate the brush 360 degrees 5 times. And what you're aiming to do there is collect some of the cells of the outside of the cervix. And you then want to immediately pop that into the pot, and you want to agitate it. So you're just trying to knock off all of those cells off the brush and into the cytology fluid. You can then withdraw the speculum and maintain dignity in the usual way. So in terms of smear tests, there sometimes is a mark for having to, or to verbalise that you are going to correctly label the sample with the patient's name, their hospital number, the date of the sample. And there's often a mark for telling your patient how and when they will receive their results. So smear tests generate a huge amount of anxiety among women. So it is important to tell them how they expect to receive the results. So in Scotland, smear tests are sent through the post. So I normally tell the women that they will receive their smear tests through the post, and it can take up to 12 weeks for that to come through. You summarise your findings, and you might want to offer to perform any additional stuff, so your bimanual swabs, ultrasound, whatever else. A word on vaginal swabs. So swabs are going to be different depending on where you're going to work. Swabs come in all shapes and colours, so don't take this as gospel as to what swabs will look like. Swabs generally are either PCR or NAT swabs, so they are amplification swabs. They are to test specifically for specific organisms, usually chlamydia and gonorrhea. To take that, you normally take an endocervical sample, so you just pop your swab just into the external os and do a 360 sweep. You then have the charcoal swab, and that is a general culture swab. So that's for things like bacterial vaginosis, things like candida, and if you wanted to culture anything, so you wanted to actually grow any of these bugs. And that's normally taken from just a high vaginal swab. Other swabs you might be asked to take are viral swabs. So viral swabs are for things like herpes, things like syphilis, areas where you think there's an ulcer. Now, with herpes and syphilis, you won't get a positive result unless you're swabbing an actual ulcer. So don't be swabbing normal skin because you're unlikely to get a positive result. So moving on to obstetrics. So we're done with gynaecology at the moment. I'm just checking the questions and answers just now. But we'll crack on with obstetrics, and I'll answer any questions at the end. So obstetric history. So as usual, we start with the usual white, washing our hands, introducing ourselves, identifying the patient, and getting consent. That is the same at all stations. So first of all, we establish a presenting complaint. And it's useful to be mindful that pregnant people can present with anything non-pregnancy related as well as pregnancy related things. So in your OSCEs, it might be a pregnant person that has a completely unrelated condition. And we ask about the history of the presenting complaint in the usual way. Again, we can use Socrates to explore the presenting complaint. And then we go on to the specific pregnancy stuff. So we want to establish gestation. How far along is she in the pregnancy? Now, patients often know their gestation, particularly if they've already been to a scan appointment. We specifically ask about the last menstrual period, and that is because if gestation is calculated from the last menstrual period with the absence of a scan. So for example, if their last menstrual period was the 1st of January and it's now the 14th of February, we can count the weeks, and her gestation is, we normally say that in weeks plus days. So she is 7 weeks plus 2 days. We want to establish her gravidity and parity, and I'm not going to go into that again, we've already went through that, but that's essentially how many times she's been pregnant and what has been the outcome of those pregnancies. I also like to ask at that point if there's been any problems in her previous pregnancies. And I like to ask when and how the pregnancy was confirmed. So was it a surprise pregnancy? Was it confirmed on a routine scan? Was it a planned pregnancy? Just gives you a bit more of a picture about the pregnancy itself. And we ask specifically about ultrasound scans and considering the gestation. So if they're very early on, they've probably only had one scan. If they're later on, they might have had multiple scans. And it's important to ask if they've had extra scans for any reason. So has there been any concern about the growth of the baby, in which case they might have had multiple extra scans. I also want to ask about other investigations. So did they undergo any prenatal testing, or did they undergo any testing for glucose tolerance tests? Thinking about routine investigations, so at pretty much every appointment, the woman gets their BMI and their blood pressure and their urine checked. But at the booking appointment at the start of pregnancy, we also test for things like a full blood count, and we also screen for bloodborne viruses, so HIV, hepatitis B, and syphilis. Additional investigations depend on risk. So risk of things like beta thalassemia, sickle cell disease does depend on where you're from and where your partner's from. So we do screen for those in certain people. Talking about prenatal testing, so most people will go for a non-invasive prenatal testing, and that's to test for things like chromosomal abnormalities, and it gives an overall risk. It doesn't tell you a yes or no answer, and that involves both an ultrasound scan and a blood test for specific pregnancy markers. Some parents will opt for invasive prenatal testing, so that is via either chorionic villus sampling performed at 11 to 13 weeks or amniocentesis performed after 15 weeks. And that gives a more definitive diagnosis that will be able to tell them if their baby does definitely have a chromosomal abnormality or not. The glucose tolerance test, so that is performed on women considered at risk of developing gestational diabetes. So things like obese women, women that have had a previous big baby, people that have had diabetes and pregnancy in the past, people with first degree relatives with diabetes, or people of certain ethnic origins will be tested for a glucose tolerance test, which gives a risk of gestational diabetes. We ask specifically about fetal movements, and be mindful of gestation. So fetal movements are normally felt kind of as early as 16 weeks, but usually felt about 18 to 20 weeks. And babies will tend to settle them down into a pattern. So they'll be most active in the afternoon or evening, and sometimes the woman will be able to tell you exactly when her baby is most active. So on average, there's up to 25 movements per hour, and there can be periods of up to 90 minutes with no movement. And that's what we call a sleep cycle. That's not worrying. And why are we concerned about this? So movements are really important to ask about, particularly in the third trimester, because more than half of women who have experienced a stillbirth had a change in their fetal movements in the run up to their diagnosis. So we take fetal movements really seriously. We also ask about vaginal discharge. And again, it is normal to have a vaginal discharge. It is normal to have more of a vaginal discharge in pregnancy, particularly as we're getting into the third trimester. And remember, a normal discharge is kind of thin, clear, cloudy, whitish, not a particularly strong smell. Anything abnormal would be kind of green, yellow, lumpy, smelly. Or if there was lots of water, is that their water's breaking? If it's red, is that blood? If there's brown, is that blood or is that meconium from the fetus? And you want to ask again about any other vaginal losses. So have they been bleeding from the vagina, and have they lost any fluid? And again, we want to think about how much has come away. Do you know, is it a huge gush of fluid, or is it a bit of wetness on the pants? We want to specifically see if they are in any pain, and we can use our Socrates to explore pain. And remember, anything non-pregnancy related can still cause pain in a pregnant woman. But common pregnancy related pains are lower abdominal pain in the first trimester. That's just due to the ligaments and uterus stretching. Back pain is very common in pregnancy, and pelvic pain is very common in pregnancy as well. And we want to think about ectopic pregnancy. Now, I have mentioned this before, but this can also come up in your obstetric stations. And not all ectopic pregnancies will present with that unilateral pain radiating to the shoulder tip. Sometimes it can be completely asymptomatic. Sometimes people can have vaginal bleeding, they can have dizziness, or they can just randomly collapse on you. So thinking about symptoms of ectopic pregnancy, particularly in a pregnant woman that has not had a scan. We also ask about uterine activity, and we're thinking about the difference here between tightenings or Braxton Hicks and contractions. So tightenings, these are normal occurrences. They occur from the second trimester. They're irregular. They can be uncomfortable, but they're not painful. They vary in length. They last less than 60 seconds, and they don't seem to have any rhyme or reason to them. They don't increase in frequency, they don't increase in intensity, and they can go away if the person gets up and walks about or if they change position. In contrast, contractions are usually regular, they are painful, they're lasting 30 to 60 seconds, and they're getting stronger, more frequent and longer. And characteristically, they will not stop regardless of position or walking about or things like that. And obviously in labour, contractions are associated with a change in the cervix. When we ask about symptoms of preeclampsia, so we're obsessed with preeclampsia in pregnancy, and we always ask about these symptoms. So remember that preeclampsia is a hypertensive disorder of pregnancy. Normally we'd see that with protein in the urine, and it is a new onset hypertension, so over 140 over 90. Normally occurs after 20 weeks, and the classic symptoms are headache, visual disturbance, epigastric pain, vomiting, and any sudden edema. Obviously, we ask about past medical history, past surgical history, particularly thinking about things like blood pressure problems, diabetes. And in terms of surgical history, we're thinking about things like abdominal operations. Have they had any operations in the past that might complicate their pregnancy? Sometimes in an obstetric station, there is a mark for performing a systems review, just because we are mindful that lots of things can affect the pregnant woman that are not necessarily directly related to pregnancy. So sometimes there's a mark for performing a quick systems review. Obviously, we ask about drug history, including vitamins, so folic acid, vitamin D, and including asking about over-the-counter medications. So remember, some medications are not safe to take in pregnancy, things like ibuprofen. And obviously, we ask allergies. We ask about family history, specifically asking if anyone in the family ever had any problems in pregnancy. And a social history is really important in a pregnant woman, because pregnancy is actually a vulnerable situation. So pregnant women are more vulnerable to domestic abuse. So we do want to ask specifically about that. And obviously we ask about what supports they've got, who's at home with them, and smoking, alcohol and drug use. And finally, we obviously establish ideas, concerns and expectations. We ask the patient if they have any questions, and we summarise our findings. And we want to again suggest preliminary investigations. So in obstetrics, that might be a CTG, that might be performing bloods, that might be a blood pressure profile, it might be an ultrasound scan. So moving on to our last station here, obstetric examination. So the usual washing your hands, introducing yourself, yada, yada. We want to gather the equipment that we need. So in terms of a proper full examination of the pregnant abdomen, you do need things like scales, blood pressure cuff, stethoscope, measuring tape. Quite often in your OSCEs, it will tell you to only examine the abdomen, but I'm going to go through the entire examination of a pregnant woman, just so that you've gone through the entire thing. So we do want to weigh the patient first, and this gives you an idea of BMI, and it can also be used to track weight change throughout pregnancy. Every woman has her blood pressure checked at every opportunity, and we always perform urinalysis, and we're looking for proteinuria, which can indicate preeclampsia. In terms of the abdominal examination, we want to describe the correct positioning of the patient. So we want the patient lying on her back in a supine position. We normally elevate the head of the bed a little bit, and if she's quite far on in the pregnancy, we want to mention the left lateral tilt. And that is just placing a pillow underneath one hip, and that's just to move the pregnant belly off of the vena cava to remove pressure there. General inspection, obviously want to see, is she comfortable, is she in pain, is she in raging labour? We want to comment on things like jaundice, edema, and I normally would say that I want to check her vital signs, her blood pressure. We start with abdominal inspection, so we do need to adequately expose the abdomen right the way up from the xiphisternum down to the pubis. And we're commenting on distension, so quite often the examiner wants you to say this person's obviously pregnant. You want to see if there's any asymmetry to the abdomen. Does it look like the baby's lying in a weird position and there's a weird lump over to one side, or a particularly longitudinal lie, or funny lumps and bumps? You can also comment on specific pregnancy markings, so linea nigra, striae gravidarum, and any scars. You also want to comment if you can see any obvious fetal movement. Sometimes you can see a wee hand or a wee foot just popping out the tummy. Here are some pregnant tummies. Here is a linea nigra. So that is occurs in pregnancy due to an increase in melanocyte stimulating hormone MSH made by the placenta, and that essentially causes certain areas of the body to darken, including the line going down the middle of the abdomen there. That is a normal finding. Striae gravidarum, that is essentially stretch marks caused by the increasing size of the uterus. And we want to look for scars, particularly C-section scars. And these can be obvious, but these can also be quite well hidden, especially if they're in just that wee crease just above the pubis. And we then move on to abdominal palpation, and there's a few stages to this, so we'll go through each stage in turn. So we normally do a general abdominal palpation, and as in any abdominal palpation, we're looking for tenderness and we're looking for masses. And we then perform a more focused abdominal examination, and here we're trying to identify the borders of the uterus. So I normally start by putting my hands either side of the abdomen and just palpating where the actual borders of the uterus is. To palpate the top of the uterus, the fundus, you want to start right the way up at the chest. You want to start at the xiphisternum, the bottom of the rib cage, and you want to palpate downwards. You can see in that second picture, and what you're looking to do is feel the top of the uterus quite confidently. And you can comment there on size. So the uterus will come up to a certain point in the belly, depending on what gestation the person is at. So classically, you can feel a 12-week uterus up above the pubic symphysis. At 20 weeks, it's up at the belly button. And at 30 weeks, it's way up at the xiphisternum. We can then assess for fetal lie. And basically what we're trying to do there is to see which way round the baby's lying. So normally to start this, I'd again place two hands on either side of the abdomen. And you're trying to feel if one side feels more full than the other. And this, if you do feel one side feels more full and more hard, that's likely to be a back, because the most common lie of the fetus is a longitudinal lie, which is lying kind of head down or bum down. If you feel that hard part on one side, feel the other side, because you might well feel some limbs. You might well get a kick if it's a particularly active baby. If you feel the uterus is very wide and you're feeling kind of hard parts on either side, it might well be that the fetus is in a longitudinal position, as shown in that bottom image there. So they're lying across the way, and that can give quite a distorted kind of look of the abdomen. It can seem quite lumpy and quite in a weird kind of shape. And babies can also be in other funny lies. They can be in an oblique lie, which is sort of a diagonal lie, usually with the head down and the pelvis on one side. And sometimes it can be quite hard to determine where the fetus is lying. If you have managed to determine the lie, we can then determine the presentation. And the presentation is simply the part of the baby that's going to be presenting itself to the outside world during birth. So to establish this, you want to feel just above the pelvic bone. You can see that in the bottom left corner, the clinicians there performing a sort of grabbing maneuver, trying to grab onto what part of the baby is presenting itself down into the pelvis. If you can feel something round and hard, that is likely to be a head, and we call that a cephalic presentation. And that is the normal presentation. That is a cephalic head down presentation. The baby's going to come out head first. If you can feel a more squishy thing at the pelvic brim, that is more likely to be a bum, and we call this a breech presentation. If you feel nothing there, it's possible the fetus is very free in the abdomen and hasn't started to descend into the pelvis, or it's possible they're in that kind of sideways transverse lie or the diagonal oblique lie. So don't worry if you can't feel anything there. If you can feel something down in the pelvis, this is quite advanced and you're not often asked to do this in your OSCE, we can then assess engagement. And engagement happens at the end of pregnancy, where the fetus starts to engage its head or its presenting part with the pelvis. And what you're trying to do here is see how much of the presenting part you can palpate above the pubic symphysis. So if it's 5/5, you can feel the whole head. The head is able to be bobbed around and it's not quite got itself stuck in the pelvis yet. and it goes down to 4/5, 3/5, 2/5, 1/5. And if you can't feel any of the head, you would describe this as 0/5 palpable, which means the head is deep in the pelvis and fully engaged. And you'd normally only see that if kind of birth was happening soon. So we then measure the symphysiofundal height. And first, you want to confidently palpate your landmarks. So your landmarks here are the pubic bone and the top of the uterus, the fundus. You've probably already felt for that in your earlier palpation. You can use a soft fabric tape to measure this distance, and be sure to follow the natural curve of the abdomen. Now, it's good practice in OSCEs to measure this kind of blind. So they quite often like you to turn the tape measure over, just so that you're not biased if you already know what the gestation is. And remember that gestation is roughly indicative of the measurement that you're getting, give or take 2 centimetres. And this measurement is most accurate from 14 to 32 weeks. So for example, if you measure 30 weeks, it's likely the person's approximately 30 weeks plus or minus 2 weeks gestation. As you get later on in the pregnancy past 38 weeks, the symphysiofundal height can actually reduce because obviously the baby is moving down into the pelvis and the fundus feels lower down. That is normal. And next we auscultate. So we are using the Pinard stethoscope there. What we're trying to hear over is the anterior shoulder. So if you've managed to figure out where the head is, you can probably manage to figure out where the shoulder is going to be. And you want to place your Pinard stethoscope over the anterior shoulder. And you want to put the big open end on the belly and the smaller flat end towards your ear. And then you want to remove your hands from the stethoscope like you can see in that picture there. So it's only your ear that's interfering with it. And if you're struggling to hear the fetal heart rate, I find that the easiest places to feel it are in the kind of lower sides, the flanks of the abdomen, as that's most likely where you're going to hear it. And in OSCE land, they want you to listen for a full minute. You're unlikely to be made to listen for a full minute, but I would verbalise that you want to listen to a full minute. And remember, a normal fetal heart is between 120 and 160 beats per minute. We then obviously summarise our findings. So I normally include things like the age of the woman, comment on their general appearance, comment on the size and the number of babies I've felt, comment on this FFH, and comment on the fetal heart. You don't need to go through everything. You're just getting a broad overview of your examination findings. And obviously then we can suggest further investigations. So for the pregnant woman, you're thinking of things like a CTG, an ultrasound test, a blood test, or a blood pressure. So that is us come to the end of our masterclass. I have successfully managed to get through a 3-hour masterclass in an hour. Thank you so much for listening. This lecture will be uploaded onto YouTube, so feel free to watch it back at your leisure. So we'll stop the recording now, and feel free to post any feedback in the